Chapter 28 discusses disorders of cardiac conduction and rhythm. So we're going to start by talking about the regular cardiac conduction system. So the purpose of the system is to control the rate as well as the direction of electrical impulse conduction in the heart. So all impulses are generated in the SA node, which is towards kind of the top of the right atrium. It has the fastest rate of firing of any cells within the cardiac system. And then those signals eventually travel their way down to the Purkinje system in the ventricles. So there's some stuff in between. We'll kind of talk about all that, but that's the general kind of top to bottom movement of cardiac conduction. So in certain areas of the heart, the myocardial cells are modified to form all of these kind of specialized cells of the conduction system that move these electrical impulses throughout the heart. And I have it highlighted here, and we've said it before, but just a reminder that the conduction system is instrumental and really important to maintaining the pumping efficiency of the heart. If you have an electrical system that is not working properly, you lose pumping efficiency as well. So all of those things that can happen when your pump isn't working well, like things like heart failure, can occur if you have a conduction system issue. So those specialized pacemaker cells generate impulses, again, at a faster rate than other types of heart tissue. And the conduction tissue transmits these impulses more rapidly than other cardiac cell types. So again, these transmission tissues are adapted specifically to transmit electrical signals. So because of these properties, a normal conduction system controls the rhythm of the heart. And another important principle to remember with conduction in general is that the fastest rate wins. And then the other reminder, again, that pumping efficiency is very important. So hearts that change structurally from things like heart attacks or heart failure also can develop less efficient electrical activity because of damage to those conductions. And so those folks are at a higher risk of things like arrhythmias because of damage to electrical conduction cells. We also see this in conditions like valve disorders that change the structure and size of the left atrium. Those folks are more likely to have things like atrial fibrillation, which affect the pumping efficiency. So a little bit more about the cardiac conduction system. The heart essentially has two conduction systems, one that controls atrial activity and one that controls ventricular activity. There are three internodal pathways between the SA node up in the right atrium and the AV node. That's kind of right between the chambers, sort of right here, including the anterior Bachman, middle Wenckebach, and posterior thoral internodal tracts. I don't need you to memorize all of those, but again, kind of you can see them in the picture right here. There's the intermodal tract, the Bachman bundle, that kind of help that electrical activity travel from the atrial area to the AV node. And then you see it as it hits the AV node head down into those kind of bundle branches. Okay. Everywhere except for the AV node in a healthy heart, the atrial muscle is separated from the ventricular muscle in order to prevent cardiac impulses firing inappropriately. So this atrial or this AV node should be the only place really relaying electrical activity from the top chamber to the bottom chamber. And again, that is really by design to prevent all of these inappropriate impulses from firing. The AV node also provides kind of a little bit of an electrical delay. So as those, we said the SA node is kind of the fastest firing, and as those electrical signals pass to the AV node is a little bit kind of slower in its conduction, and it allows less impulses to travel through. So there's kind of, again, a little sort of delay of electrical movement right here at the AV node. That's important for heart pumping efficiency. So that delay provides like a mechanical advantage where the atria can fully complete their ejection of blood into the ventricle before that ventricle contracts. And so they make sure that little delay helps to make sure that preload into the ventricles is maximized before that ventricle will contract. So the main function there is to coordinate that atrial and ventricular conduction and then contraction. The Purkinje system initiates the ventricular conduction. It has really large fibers that allow for rapid conduction. So you can see those Purkinje fibers kind of traveling here throughout the ventricles. So there's that really large ventricular area that needs to have really rapid electrical conduction to be able to contract forcefully and kind of efficiently all at the same time. So these fibers, again, are really large and conduct really rapidly throughout that ventricular tissue. And also because of its proximity to the aortic valve and the mitral valve ring, the bundle of His is really predisposed to inflammation and deposits of calcified debris that can interfere with impulse conduction. So the bundle of His is something that often, you can see it kind of right here. The bundle of His is where we leave kind of the AV node. That is an area that can become damaged because of various things, again, like calcified debris of the aortic valve or the mitral valve itself. The AV nodal fibers, when not stimulated, do have their own kind of intrinsic pacemaker. So again, normally we go through the SA node and that signals the AV node. But if we lose that SA node conduction for some reason, the AV node does kind of have its own sort of intrinsic pacemaker to it, and it'll fire at about 40 to 60 times a minute. The Purkinje fibers also have the kind of their own sort of pacemaker, but it's at about 15 to 40 times a minute. So if the Purkinje fibers lose their impulses, they can still fire, but at a much slower rate. So what is controlling this electrical activity? Well, it's the action potentials or the resting membrane potentials in these electrical cells of the cardiac conduction that cause that electrical activity. So during the resting phase of the membrane potential, the membrane is selectively permeable to K and nearly entirely impermeable to sodium. So as a result of this, K plus diffuses out of the cell along its concentration gradient. Remember that K plus is very prevalent inside the cell. So K diffuses out, and it causes a loss of positive ions from inside the membrane. And so that's what we see here at this resting state, where we have positive charge outside, negative charge inside, and this is the resting membrane potential. During depolarization, positive ions, and this is going to be sodium, kind of rush into the cell, changing that polarity, which reestablishes itself during repolarization. So we'll look at that in a little more detail. So these are the phases of cardiac potential that are created by those changes in action potential. So we have three membrane embedded ion channels that are responsible for this activity. They're the fast sodium channels, the slow calcium channels, and the potassium channels. And as electrical activity is initiated, it travels cell to cell kind of in a wave across the heart that creates that electrical conduction. So we'll start with phase 0 right here. And so this is the rapid upstroke of the action potential. And during this phase, sodium channels open when they reach their depolarization threshold. So when there's a single signal strong enough to cause depolarization, those sodium channels open and sodium floods into the cell, making the cell interior highly positive. And so again, those are those fast sodium channels. So we see this rapid upstroke moving from that resting membrane potential at its negative pole all the way up to this much more positive phase 0 depolarization. At phase 1, this is what we call early repolarization, kind of right here on this small downstroke. That's when the sodium channels close. So that rapid influx of sodium ions stops, and we have a very small kind of movement back towards negative, almost the start of a repolarization here. Okay. At phase 2, we have a simultaneous influx of calcium into the cell through these slow calcium channels. And this produces kind of an elongation of the contractile process, and it contributes to this kind of phase 2 plateau that we see. So we no longer have that sodium rushing in, but we want to maintain kind of that depolarization for a little bit longer to enhance contractility of the heart. And so calcium is what is responsible for this kind of plateauing. And that is creating, again, kind of more efficiency, more time for contraction in that pumping mechanism of the heart itself. So again, slow calcium channels are open. We get this slow influx of calcium that maintains kind of this positive ion polarity that we see during the phase 2 plateau. These unique features of that phase 2 plateau, again, cause the action potential and the contractility of cardiac muscles to last a little longer than that of kind of a skeletal muscle. That is actually that, we'll look at this in a second, but that's the ST segment of the EKG portion of that polarity. In phase 3, that's when those calcium channels close and potassium starts to make its way out of the cell. So phase 3 is the final repolarization period. You see that here we're returning back towards that resting membrane potential. And then phase 4 is the total return to resting membrane potential. And that's when the sodium potassium pump starts to help us return here with transport of sodium out of the cell and potassium movement back in. This corresponds to diastole within the heart. The rest of this was systole. So now we're back to repolarization and we have diastole and relaxation of the heart muscle. So this is, again, that phase 4 is the diastolic repolarization period. So this is how that looks in comparison to the electrocardiogram and the phases of the ventricular action potential. Again, we see phase 0, 1, 2, 3, 4. So we see that kind of, this is where that signal comes in that is enough to cause depolarization when the sodium channels open and we have that rapid influx. So this is what we call the P wave of the EKG. That's that initial depolarization of the atria. So we start at the SA node and the atria depolarize first. So those that electrical signal is going to kind of move across the heart in sort of a wave. So that smaller atrial chamber depolarizes first. The EKG picks up that electrical activity, and that's what forms what we call the P wave on an EKG. And then depolarization continues. And as it hits the AV node, remember we said that there's that kind of bit of contraction, or excuse me, electrical activity delay in the AV node that allows for that really efficient kind of full filling of the ventricles before they end up contracting. That's where we see this on the EKG. So there's that little delay of electrical movement through the AV node that causes a bit of a pause in electrical activity, even though we have depolarization happening, right? And then we get this kind of depolarization that moves very fast through the Purkinje fibers of the ventricles that causes this big change in electrical signal as those ventricles depolarize, okay? We call this the QRS complex, which corresponds with ventricular firing. And that happens kind of while we have that plateau phase of electrical activity that allows that kind of lengthening of contraction, which maintains our good efficiency. As we quickly move back towards repolarization in phase 3, that repolarization phase shows up on our EKG as the T wave on an EKG tracing, until finally we get back towards baseline, where we have complete resting membrane potential back into diastole. So how do we look at these electrical signals for our patients? Typically, we use what we call electrocardiography or a 12-lead EKG. These are diagnostic EKGs, provide a unique view of all of the electrical forces moved through the heart. We've talked about EKG already quite a bit when we've had our discussions of things like pericarditis and heart attacks and how those look as EKG. But these provide a diagnostic criteria that are very lead specific. So every lead that we attach to the chest gives us a different view of the electrical activity moving through different portions of the heart, which can aid in the diagnostics of cardiac dysfunction very quickly in our patients. But one thing to understand about electrocardiography, because each lead is very specific to different portions of the heart muscle, if we don't put those leads on properly, it can significantly change the way we look at that QRS complex morphology in the heart. So improper lead placement can lead to improper kind of diagnostics in the heart itself. So lead placement is very important to get a correct and appropriate picture of what's going on with the electrical activity. Because misdiagnosis of cardiac arrhythmias or the presence of conduction defects can either be diagnosed when they're not really there or can be missed if we don't place those leads correctly. So this is kind of what that looks like. We have 6 limb leads and 6 chest leads. We use 10 electrodes to get 12 separate pictures of what the heart looks like. So we put leads kind of in the periphery and then all across the chest in very specific locations. And what that ends up doing is it creates kind of these electrical pictures or vectors through the heart that give us very specific pictures of what electrical activity is looking like as it moves through that heart in kind of that wave. And this is how an EKG can give us a good diagnostic picture of how electricity is moving. And if there are any kind of defects or problems happening in the heart, like ischemia, that would be interrupting some of that electrical movement. Okay. And again, here's our electrocardiogram. So this is a diagram of the electrocardiogram. It's specifically from one lead, lead 2, and it represents the depolarization and repolarization of the atria and the ventricle. So again, the P wave right here represents the atrial depolarization, and the QRS complex represents the ventricular depolarization. The T wave represents ventricular repolarization. Okay. Atrial repolarization occurs during ventricular depolarization, and so it's hidden within the QRS complex. So while the ventricles are depolarizing, the atria are repolarizing, getting themselves ready for the next contraction. You just can't see it in the EKG like you can the repolarization of the ventricles, because it's just kind of buried in that stronger electrical activity that we see when the ventricles depolarize. Okay. And so when we name the electrocardiogram, we call this the P wave, the QRS complex, and the T wave. And we call this, if you look over to the right, the PR segment is between when the atria start to depolarize and when the ventricular depolarization occurs. We call that the PR interval. We call the QRS duration that time when the ventricles are depolarizing. We call this the ST segment between the end of ventricular depolarization until the repolarization starts. We call that our ST segment. And so those are some of the kind of main nomenclature we use to describe an electrocardiogram. So many patients are getting bedside kind of cardiac monitoring. And this was a shift from just simple heart rate monitoring, so just what is a heart rate, to being able to really monitor more closely for things like arrhythmias. Because bedside cardiac monitoring can identify things like ST segment changes, which might be indicative of things like, again, pericarditis or MI. They have the ability to do some advanced arrhythmia identification, so we can identify arrhythmias earlier and treat them in our patients. They can help us diagnose different cardiac issues. and they speed up the time between identification of arrhythmias and when we can provide treatment. So typically, if we're going to use bedside cardiac monitoring, we have to have kind of a reason for risk or concern in our patients to do this. We don't cardiac monitor every single patient that comes into a hospital. There is cost to doing this, and there are a lot of patients who just don't have enough cardiac risk factors to justify monitoring their cardiac rate and rhythm at all times. So we put people into kind of different classes to determine whether or not they need cardiac monitoring. So class 1 patients would be patients where cardiac monitoring is necessary in most, if not all, people within this group. So those would be high risk people for cardiac disease, and so they would need monitoring at all times. All the way to kind of a class 3 where cardiac monitoring would not be indicated because there's really no risk of serious event for those people, or it's so low that monitoring would not be viewed as therapeutic. So again, it's important to kind of put people into different risk stratifications to decide who would benefit from cardiac monitoring at the bedside and who is so low risk there would be no real therapeutic benefit. So then we'll talk about some of the different types and causes of disorders of the cardiac conduction system. So one thing to understand is that arrhythmias are not necessarily pathologic. Some people have arrhythmias that are really pretty benign and don't really cause any problems. And know that arrhythmias can occur in both healthy and diseased hearts. So usually when cardiac rhythms start to cause problems, it's because their harmful effects are interfering with the heart's ability to pump. So if you have a cardiac dysrhythmia that doesn't change the pumping ability of the heart, it's not really necessarily pathological for the patient. They might feel dysrhythmias or little extra heartbeats. It might be annoying to them, but if it's not changing the pumping efficiency, we don't necessarily consider it a pathological condition that needs to be treated. But things like excessively rapid heart rates or tachyarrhythmias can start to reduce the diastolic filling time. So that would cause a decrease in stroke volume and output and things like cardiac coronary perfusion. And they also, as that rate increases, increase myocardial oxygen demand. So things like tachyarrhythmias, because they increase workload and also change efficiency, would be considered pathological. Same with abnormally slow heart rates or bradyarrhythmias. These impair blood flow to vital organs like the brain because there's a decrease in cardiac output because of that significantly reduced heart rate. So those are some examples of when we have a disturbance or a dysrhythmia that then leads to things like changes in cardiac output or pumping efficiency. So the types of dysrhythmia that we can see, they can be disorders of the rhythm itself, and they can also be disorders of the impulse conduction. So both things can cause disturbances in heart rhythm, disorders of rhythm as well as conduction. So we can have normal rhythm, but it just can't move correctly through the heart, and that's when we have an impulse conduction problem. Lots of things can cause changes in cardiac rhythm, so things like congenital defects or degenerative changes within the conduction system itself. Myocardial ischemia and infarction are common causes of disorders of the cardiac system. Other things like fluid and electrolyte imbalances, we talked about all the essential ions like sodium, calcium, and potassium that help to maintain those action potentials in cardiac conduction tissue. If we get imbalances in those electrolytes, either from fluid problems or from electrolyte problems themselves, it can change conduction. And also effects of drug ingestion. We have a lot of drugs that affect the balance of things like especially electrolytes within the body. So many of those drugs can also change electrical conduction throughout that cardiac system. So a little bit more about the properties within those specialized conduction cells themselves and how they help to maintain electrical activity within those specialized cells. So the specialized cells in the conduction system of the heart have 4 inherent properties that contribute to the genesis of all cardiac rhythms, both normal and abnormal. They're automaticity, excitability, conductivity, and refractoriness. An alteration in any of these four properties can produce arrhythmias or conduction defects through the heart. And so remember, arrhythmias are problems of rhythm, and conduction defects are problems of conduction or movement of that rhythm. So automaticity means that these cells can spontaneously initiate an impulse or action potential, meaning they are what we call an ectopic pacemaker. So remember we said that the SA node is the primary pacemaker of the heart, but that the AV node and the Purkinje fibers, if they're not signaled, can also produce their own electrical activity. That is that automaticity. So all of these cells can fire at their own inherent rate. And so this helps to protect us. Like if we lose SA node conduction, we'll still have some heart rate, right, from the AV node or from the Purkinje fibers that still maintains that conduction. But this automaticity also is what causes a lot of our arrhythmias, because we can get these kind of ectopic pacemakers or these abnormal firing of electricity when a different cell within the heart decides that it's going to fire. It can kind of take over and start an arrhythmia independent of the normal SA node pacemaker. And sometimes those ectopic signals that are coming from somewhere other than the SA node can start this sort of rapid, sort of circular conduction that causes the heart's electrical activity to move faster than what we would see in the SA node. And then remembering that whatever's fastest takes over, if we get a really fast rhythm coming from someplace else in the heart, it will propagate itself and just become the normal rhythm. So that's what we see in things like atrial flutter or atrial tachycardias that we'll talk about in a moment. We get these really fast heart rates, right? Like well over 100, sometimes up to 180 beats per minute or maybe even faster, that now have kind of taken over because of this automaticity, letting an aberrant kind of heart rate kind of take over. So again, this is important to keep us with a heart rhythm, even if something goes wrong, but it also often contributes to the development of arrhythmias inside the heart. So instead of, they start and instead of dying out, they just kind of re-enter into the system and propagate themselves. Another property is excitability. So this is the ability of a cell to respond to an impulse and generate an action potential. And so as the SA node fires, we need it to signal the next cell and then the next cell and the next cell. They need to be excitable so they can pick up that kind of cell-to-cell transfer of the electrical activity throughout the heart. If that excitability is damaged and we can't move from cell to cell, then we can get kind of a block in electrical conduction. And that can cause, a problem with heart electrical conduction, right? And so this can happen when there's some kind of scar tissue. So maybe we have a patient who has had like a major problem, maybe they have an aortic valve or a mitral valve problem, which is causing transfer of scar tissue or calcification to hit that kind of bundle of His, which is right past the AV node in the heart. And if enough scar tissue and calcification happens at that point, it can block electrical activity completely from the atrium to the ventricle. And now we have a patient in complete heart block because we've lost that excitability. We've lost, due to scar tissue formation, that ability of that electrical impulse to move kind of cell to cell. The other piece is conductivity, kind of the same sort of mechanism. If we lose conductivity as well, that ability to conduct impulses, again, often through things like scar tissue, we can get a block in conduction where that would occur. And the final piece is refractoriness. This is the extent to which the cell is able to respond to an incoming stimulus. There is a certain amount of time, usually where the cells are in that phase of depolarization, where they have not reached repolarization yet, where no matter how much signal you send to that cell, it's not going to be able to depolarize and contract again. Refractoriness is important because we want that time where we can't signal another contraction, or where we don't have a electrical cell that can respond to another incoming stimuli. without that refractoriness period, or if we shorten that refractoriness period, we have a heart that's more susceptible to some of that automaticity piece, where we can get some of those tachycardias that can re-enter and signal, cause signals to propagate these abnormal electrical things like, atrial tachycardias. So refractoriness is again important to maintain kind of that normal cardiac conduction throughout the heart. So we'll talk about some different types of arrhythmias. So arrhythmias can be coming from the sinus node itself, so from the normal pacemaker. So these are things like sinus bradycardia, sinus tachycardia, or sinus arrest when the sinus node stops firing. And they can also be arrhythmias of atrial origin. So these are things like paroxysmal supraventricular tachycardia, atrial flutter, or atrial fibrillation, where that abnormal heart rhythm is coming from someplace within the atria itself, but not from the sinus node. So these things are independent of the sinus node. There's some other ectopic pacemaker that has taken over the rhythm and is sort of muting the sinus node itself. So it is not able to kind of fire and run the electrical activity. So these are what some sinus rhythms look like on EKG. A is normal sinus rhythm. So remember that this is typically 60 to 100 beats per minute, and that's what that looks like on EKG. B is sinus bradycardia. This is when the electrical signal is still coming from the sinus node, but it's slower than 60 beats per minute. C is sinus tachycardia, so we're still coming from the sinus node, but the rhythm is greater than 100 beats per minute. This final one is what we call respiratory sinus arrhythmia. You can see it's a little bit irregular. We have QRS complexes coming in at sort of irregular intervals, but you can still, this is still sinus driven. There's a little P wave here, which is what tells me this is sinus driven, but there's some irregularity here. That's usually from respiratory rhythm in some folks. These are what the atrial arrhythmias look like. So again, these rhythms are coming from the atrium. So there's an ectopic electrical signal somewhere in the atria that is taken over. These are no longer sinus node driven. So the sinus node may still be firing, but it's muted essentially by this much faster atrial rhythm. So this first one is what we call atrial flutter. You can see these kind of like sawtooth or fluttery looking waves. This is the electrical activity coming from the atria, but you can see it's much faster than what we normally see in a sinus node-driven rhythm, and that there's a lot more of these atrial depolarizations than you see ventricular depolarizations. So that's characteristic of an atrial flutter. The rate in the atrium here is probably something like 240 to 450 beats per minute. But the ventricular rate remains regular because it's only really conducting every like 4 to 6 atrial contractions. So that natural kind of slowdown through the AV node is sort of protective here so that our heart rate isn't really fast. If that were to happen, right, if every single atrial depolarization caused a ventricular depolarization, we'd have a really fast heart rate and we would have no time for diastolic filling. And so our patient would be in trouble, right? The second tracing is atrial fibrillation, where we see an even more kind of grossly disorganized atrial electrical activity, and it's very irregular. You see the QRS complexes are much less regular than we saw in atrial flutter. There are no distinct P waves, and so again, that's really very distinctive of atrial flutter. The third tracing is paroxysmal atrial tachycardia. It started out kind of as a normal sinus rhythm, and then this kind of really fast rhythm sort of took over here at the end. And the fourth tracing illustrates what we call premature atrial contractions. So we have these normal sinus QRS complexes, P wave, so atria ventricle, And then here, for some reason, we have some abnormal ectopic pacemaker in the atria that decides to fire much earlier than the SA node. So we get this kind of really early firing that signals a QRS complex and ventricular depolarization at a much earlier time than would normally be expected with normal SA firing. So in healthy people, PACs are very common. They can result from things like stress, alcohol ingestion, tobacco use, significant caffeine ingestion. They are also sometimes associated with MI, digitalis toxicity, low serum potassium or magnesium levels, and hypoxia. Again, for the most part, they're benign, but they often do have kind of a trigger that might signal another underlying problem. So we're going to talk a little bit more about atrial fibrillation because AFib is a very common condition. The estimate is that maybe 10 to 15% of the population experience atrial fibrillation, and it's probably honestly higher than that because a lot of folks are experiencing it and don't know they have it. So atrial fibrillation has atrial rates, so electrical activity in the atria, that are about 400 to 600 beats per minute. So just again, this really fast, disorganized firing of the atrium. The other hallmark of atrial fibrillation is that there are no P waves on an EKG. So I have an EKG of atrial fib here, and you can see on that kind of tracing that it's all just this kind of really disorganized, kind of like just, you know, fluttery kind of activity from the atrium. There's no real organization here. None of these depolarizations are large enough to create any sort of distinctive P wave. It's not coming from the SA node itself. Usually atrial fibrillation originates in the left atrium, usually around the pulmonary veins. All of these just electrical activities that are sort of coming from everywhere. The QRS complex remains usually between 80 to 180 beats per minute, because that the AV node doesn't allow all of those contractions to make it through, which again is a good thing because we would not survive this otherwise. But sometimes, depending on the speed of the ventricles, not all of the contractions of the ventricles may be palpable, meaning if you take someone's peripheral pulse, like at their radial pulse, you might not feel every single one of those QRS complexes as a peripheral pulse. We call that a pulse deficit. And this is why with patients with really irregular heart rates, we often advise you to take their pulse apically so you can hear every contraction rather than trying to feel them, because you may miss a heartbeat and then you would undercount this patient's heart rate. We have three different kind of distinctions of AFib. They are paroxysmal, persistent, and permanent. Paroxysmal AFib is that AFib that will self-terminate, meaning we go back or revert to a normal sinus rhythm on our own, and it usually lasts no longer than 7 days. Persistent AFib lasts greater than 7 days and usually requires some sort of intervention like cardioversion or medication administration to convert that person back into a normal sinus rhythm. Once we convert them back into normal sinus rhythm, we try to use medications and then avoidance of AFib risks to keep them in that normal rhythm. AFib is classified as permanent when all attempts to terminate atrial fibrillation fail and the person just remains in AFib. So those are the three different kind of classifications of atrial fibrillation. Again, this is the most common chronic arrhythmia that we see in patients. It can happen in those without any apparent heart disease or in patients post-MI. It's pretty common in mitral valve disease because of the location of the mitral valve in the left atrium. It also happens frequently in patients with CHF, hyperthyroidism. There are a lot of other kind of causes of it too. So lots of causes means very common condition. So with atrial fibrillation, the most common clinical manifestations we see in our patients are palpitations, Fatigue, because it does affect cardiac output. So these patients are often fatigued. And the major complication that we see with atrial fibrillation is thrombus formation in the left atrium that can cause stroke in our patients. So you can see that on my diagram here. So we have atrial fibrillation, which largely originates in the left atrium, which is right here. And because that left atrium is not efficiently moving blood through it, the blood kind of sits and pools within the left atrium. And from what you already know about pooling or stasis of blood, that predisposes us to the formation of a clot. If a clot forms in the left atrium, it can then move into the left ventricle. So you can see that from the kind of the little white line here. And if a clot moves in the left ventricle, it can be ejected out into the aorta. And because of the way our anatomy is set up to send oxygenated blood to the brain first, right? That's important because the brain needs a good supply of oxygen, but it also creates a direct line, right, where an atrial clot can move very rapidly, quickly, and straight up into the cerebral circulation itself. So our clot moves from the LA to the LV into the aorta, directly up through the common carotid artery, all the way up into the brain, where it can cause an embolus to block the blood flow, causing a stroke. So stroke is a major complication of atrial fibrillation. Another complication can be pulmonary edema. Because atrial fibrillation, especially fibrillation that causes really rapid conduction into the ventricles, can significantly reduce our cardiac output. That can cause heart failure, leading to pulmonary edema as that blood backs up from the left ventricle into the pulmonary circulation. So again, those are kind of the two main significant complications that we see of AFib: stroke and pulmonary edema from left-sided failure. So the treatment for atrial fibrillation is antiarrhythmic medications to try to both restore normal sinus rhythm as well as to slow the ventricular heart rate to prevent things like that left ventricular failure. We also use anticoagulant medications in these patients to prevent the formation of a thrombus in the left atrium. And we can also use something called cardioversion, where we provide a strong electrical current through the heart externally to try to restore the regular rhythm of the heart. We especially use cardioversion in patients who might be unstable. So again, these are the patients with really rapid ventricular rates who might have really low blood pressure, really poor cardiac output, and the danger of things like pulmonary edema and heart failure because of those rapid rates. Another type of arrhythmia are those that we term junctional arrhythmias, or that we term kind of disorders of ventricular conduction and rhythm. So these are things like long QT syndrome and torsades, and also ventricular arrhythmias. So these are premature ventricular contractions, ventricular tachycardia, and ventricular flutter or fibrillation. So these are all the conduction defects that are happening below the atria. So we talked about the atrial defects, and now we're going to talk about things below the atria, things from the AV node junction or from the ventricle itself. So we're going to start with junctional rhythms. So this is a tracing of what we call a junctional EKG. And so this is a rhythm coming from the AV node itself. So the SA node, probably from something maybe like a sinus arrest, is no longer firing and signaling the AV node. And so now in a junctional rhythm, the AV node becomes the pacemaker. And remember, we said that the AV node has an intrinsic rate of its own of about 40 to 60 beats per minute. And so this EKG tracing is much slower than what you see in a sinus rhythm. The other thing that I don't see here is any P wave. There's no depolarization of the atria on this tracing because the rhythm itself is coming directly from the AV node. So this is a junctional EKG. This tracing shows something called a bundle branch block. These are usually benign in our patients. They usually don't cause any alterations in the rhythm of the heartbeat. But because, remember when we saw the picture of all of the kind of Purkinje fibers and all of those branches that are signaling the ventricular fast conduction, if one of those conduction fibers becomes blocked, we get these kind of wider and slower conduction through the ventricles themselves. We still have relatively good conduction because there's two other bundles of electrical activity to take their place. It's just maybe a little bit slower, and it might be a little less efficient than what we normally see, but it normally doesn't cause our patients any trouble. But this is what you'll see on EKG, this kind of widening of that tracing. This rhythm is what we call torsades de pointe. And so you can see these are ventricular depolarizations. And you can kind of see them moving in sort of this cyclical pattern where the depolarizations kind of get really large and then a bit smaller, larger again, smaller. So this is really common, this sort of oscillating pattern. There's a condition called long QT syndrome or long QT polarization. So it's prolongation of the QT interval on EKG. And that's what often precedes this dysrhythmia of the ventricles. Sometimes that's caused by a hereditary form or a genetic issue that causes changes to the membrane ion potentials, usually changes to sodium channels. Or it can also be an acquired condition, usually predisposed by something like an electrolyte imbalance. Usually magnesium is the electrolyte imbalance that would cause this. Sometimes we see it after MI or maybe with a brain hemorrhage. Sometimes there are some medications that can cause this, like DIG or verapamil. This condition, though, where we have that long QT syndrome, whether it's caused by a genetic cause or by again, electrolyte disturbance or drug ingestion, this causes, this is a lethal dysrhythmia that can cause sudden cardiac death in our patients. So kind of going back, if we are identifying an elongated QT on EKG, we know that that can predispose our patients to this condition. And so we would start to look for reasons for that to be happening. If it's a genetic cause, this patient may need an implanted cardioverter defibrillator to prevent this rhythm. If it's a reversible cause of long QT, like a medication or like a magnesium deficit, we would correct that underlying cause to prevent this rhythm from happening. These are some other ventricular arrhythmias. The top tracing is a PVC or a premature ventricular contraction. So this is some ectopic or abnormal beat from the ventricles themselves that's causing early contraction of the ventricle. This early contraction happens before the ventricle entirely fills. So this premature ventricular contraction will not cause an efficient or sufficient amount of stroke volume to really be perfusing the body. So if you were to be feeling someone's peripheral pulse while they had a PVC, you would most likely not feel that contraction in the periphery because the ventricle itself did not have time to fill before it decided to fire. So a palpable pulse would be absent or at best significantly diminished during that PVC. But PVCs are also relatively common. And if they're happening in the absence of heart disease, they're usually not typically clinically significant. But the incidence of PBCs, or these premature contractions, rises when a patient's heart muscle is experiencing ischemia, or if there's an MI, or sometimes they increase when the ventricle is hypertrophied. They also increase with things like infection or increased sympathetic nervous system activity. They can also increase when the heart rate itself increases. So again, they're usually insignificant, but if there is some sort of damage or problem happening with the heart muscle, we do see them overall increase. So they can be a sign of some other underlying problem. PBCs can also be the result of electrolyte disturbances, or they can happen with medications. Um, the middle rhythm here is ventricular tachycardia, or VTAC. This rhythm is dangerous because it eliminates any atrial filling of the ventricle, and it can also cause a significant reduction in diastolic filling time to the point where cardiac output is severely diminished or even non-existent. And if we get non-existent ventricular filling, this patient will also have non-existent cardiac output, and then it becomes a lethal rhythm. The final rhythm that you see on the bottom is ventricular fibrillation. VFib is a severe derangement of cardiac rhythm that terminate fatally within minutes unless corrective measures are taken promptly. So in this patient, there is absolutely no ventricular contraction at all happening here. And with no ventricular contraction, there is absolutely no cardiac output in this patient. So this is essentially, in a fibrillating heart, a patient with no forward blood flow. This is a patient that, unless we rapidly correct this rhythm, this patient will die. We correct this rhythm using direct cardioversion, or shocking of the heart muscle itself. So unlike things like atrial fibrillation or atrial flutter, where a patient, because of slower ventricular conduction rate, can withstand that rhythm, in ventricular fibrillation, without immediate and rapid cardioversion of this patient, they will die. This needs to be corrected immediately. So the final type of arrhythmia that we'll talk about are conduction defects within the AV node, or atrioventricular conduction defects. So conduction defects of the AV node are most commonly associated with fibrosis or scar tissue in the fibers of the conduction system. So conduction defects may also result from sometimes medications, so things like digoxin or beta-adrenergic blocking agents, calcium channel blocking agents, and class 1A antiarrhythmic agents can also cause this. So patients who suddenly start to develop disorders of atrioventricular conduction, we would want to look at medications that they're taking. Other things that can cause this are things like electrolyte imbalances. We also see AV node conduction problems during acute MI. We see it with idiopathic fibrosis in the conduction system. Inflammatory diseases of the heart can also cause cardiac conduction problems. And we also see them post-cardiac surgery. Some patients, because of damage to the conduction system during surgery, do not regain good AV conduction. Other less common causes might be infections, autoimmune diseases, neoplasms, or what we call iatrogenic disorders. We can get first-degree AV block, second-degree AV block, or third-degree AV block. So this is what they look like on EKG. So first-degree AV block is just a prolongation of electrical activity through the AV node. It's just taking longer for the conduction to move through than normal. This is usually asymptomatic. All the beats do end up getting transmitted to the AV node. It's just taking longer. So this is first-degree AV block here. So the PR interval, that time between atrial depolarization and ventricular depolarization, is just longer than normal. Eventually they get there, it's just slow. So again, usually benign, we don't really worry about that in a patient at that point. Second degree AV block is intermittent failure of conduction of one or more impulses from the atria to the ventricle. So at this point in a second degree block, not all impulses from the SA node are able to transmit through the AV node. So there's some atrial depolarization that does not result in ventricular depolarization. So some types of second degree are not symptomatic, but some are and are associated with high mortality in patients and would mean they would need a pacemaker. So it really depends on the adequacy of the ventricular rate. But essentially, the fewer beats that are able to transmit into the ventricle, the more risky it is for our patient. So you can see that here on this middle tracing. So we have a P wave or atrial depolarization followed by ventricular polarization. But then here we have a P wave that comes in and it does not end up getting transmitted to the ventricle. So this P wave has no ventricular depolarization. So this is sort of what we call like a dropped P wave. Nothing happens, no movement through the AV node. And so then it fires again. Our SA node fires again. We have atrial depolarization, and this time it makes it through. But over here, it fires again, and same thing, doesn't make its way through the AV node. And so the less movement through the AV node with corresponding QRS depolarization, the more risky it gets for our patients. So sometimes second degree blocks, our patients do okay. There's enough movement to the ventricle. And in other cases, we just don't have enough conduction into the ventricle to keep our patients safe. The final type of AV block is a third degree or what we call complete heart block. AV block occurs when the conduction link between the atria and the ventricle is completely lost. So we have complete interruption of conduction through the AV node. And then what we get is a complete dissociation between the rate that's being produced in the SA node and the rate that's being conducted into the ventricles. So complete heart block causes a decrease in cardiac output with possible periods of syncope or fainting in our patient. Most cases of third degree block require a pacemaker to be inserted to take over the cardiac rhythm. So this tracing on the bottom is third degree heart block. There's a complete dissociation of what's happening in the electrical activity in the atria and what is happening in the ventricle. So the SA node just keeps on firing at its normal rhythm. So you see P wave, P wave, P wave, P wave. It's pretty regular because the SA node's just firing away. But the QRS rate is completely different. It's being driven probably by the intrinsic pacemaker at the AV node itself. So it's firing completely independent of what's happening in the atria. So complete dissociation in this patient between the electricity at the top and at the bottom. So those are different types of cardiac dysrhythmias. So let's talk a little bit about some diagnostic methods, and then we'll talk about some treatments for these. So signal averaged electrocardiogram, we talked about that. This is our 12-lead EKG. This is a very common diagnostic method that we use to determine the type of arrhythmia or conduction problem that our patient is experiencing. Another diagnostic that we can use is something called a Holter monitor. You see that up here. That's a monitor that a patient can wear for maybe 24 to 48 hours. This is a patient who might come in and say they're feeling a lot of palpitations or maybe shortness of breath or some kind of other complaint that might make us think that they're having some sort of dysrhythmia, but we're not able to capture it like in a clinic or in an ER on a EKG because they're kind of in and out of that rhythm. We might send them home on a Holter monitor trying to pick up that dysrhythmia, if it's only happening every once in a while. Usually these monitors are triggered by fast heart rates, and oftentimes they have kind of a little button that a patient can also push. So if a patient feels those palpitations that have been bothering them, they can push a button so that the Holter monitor starts recording at that point. We also have something called a loop recorder. That's this picture down here on the bottom. These are little implantable devices that get inserted just right under someone's skin, right over the heart. They don't have any leads or anything that within. They're just this kind of little thing that looks sort of like a flash drive that you might use in a computer. And these will pick up electrical dysrhythmias just like a Holter monitor would, but there's no external wires, there's no internal wires. So patients can have these implanted very quickly. It's maybe a procedure that takes maybe 10, 15 minutes, just local anesthetic right under the skin. And then they go home with this recorder. And so this is for a patient who, again, maybe has some dysrhythmia that we haven't been able to pick up either on diagnostic EKG or on a Holter monitor, but it's still something that's bothering them. They can have these loop recorders in for extended periods of time. They have little batteries in them. Eventually the battery dies, but they can be inserted for like a year or more to pick up dysrhythmias. We can also use exercise stress testing. Sometimes we can induce dysrhythmia, especially when the heart is um, undergoing periods of ischemia. So if we increase the workload of the heart like we normally do during an exercise stress test, sometimes that also induces dysrhythmias in patients. So that can be diagnostic for them. And then we also have something called electrophysiologic studies, where we bring a patient in and hook them up to a whole bunch of electrodes. And then we actually insert catheters into the heart itself and administer various electrical signals at different points of the heart, trying to induce a dysrhythmia. That helps us determine if a patient does have abnormal heartbeats. It helps us to determine kind of where those electrical signals are coming from or the type of dysrhythmia that a patient is experiencing. And so these are some ways that we can correct conduction defects, whether they're bradycardias or tachycardias. So some patients, especially for bradycardias, things like sinus arrest or second degree or third degree heart blocks, these patients may need electronic pacemakers. These pacemakers can be temporary, where we maybe insert wires into the veins, into the jugular vein and into the heart. This might be something we use if a patient maybe has, a drug-induced bradycardia or complete heart block that we expect to reverse once that drug is no longer in the patient's system. Or maybe we use a temporary pacemaker immediately in a heart post-operative period, where we think that the heart muscle may just be kind of temporarily sort of stunned, but the patient will regain that electrical activity eventually once the heart muscle the inflammation goes down and the heart muscle kind of starts to heal. We might use a temporary pacemaker for that patient. And then once conduction is restored, we can remove that pacemaker. But if we don't anticipate that electrical activity will be restored, then we use something like a permanent pacemaker. This picture on the right is a permanent pacemaker. So there's a small battery inserted underneath the patient's either subcutaneous tissue or deep into the muscle for some patients. And there are electrical conducting leads attached to that little battery. There's also kind of a little brain in there that tells the pacemaker how often to fire. But those leads are then inserted usually into a large vein in the chest, usually subclavian vein. And this is all happening underneath the skin. So all of this is completely buried. But we get those wires into that vein, and then they travel within the vein into the heart. And usually we put one lead into the atria and then one lead into the ventricle, so that we can have good atrial ventricular conduction. And so this bypasses the normal conduction system in the heart for a patient who either has, again, maybe sinus arrest or an AV node conduction problem, so that we can restore conduction and keep this heart beating. I had mentioned cardioversion before. There are two types of cardioversion. There's defibrillation, and this is the type of cardioversion we use in a patient in ventricular fibrillation. This is a type of electric shock applied to the outside of the patient's chest in a very kind of rapid way. The timing of when we administer that shock in relation to the patient's normal cardiac function is irrelevant in this patient. It doesn't matter where in the cardiac conduction we deliver the shock, because this heart is fibrillating. It's not doing anything that resembles any type of normal conduction. So we just administer what we call an asynchronous shock directly to the chest to try to restore normal cardiac function. So again, defibrillation is what we use for a patient maybe in ventricular fibrillation, or a patient who is unstable and unconscious and ventricular tachycardia. Synchronized cardioversion is what we use in a patient who maybe has an atrial dysrhythmia. So this patient is usually awake and aware, but they're potentially unstable, meaning they have a low blood pressure, low cardiac output, and so we need to restore regular rhythm. But because this patient does have some sort of normal or some sort of electrical conduction, we can't just administer that shock wherever within that cardiac conduction. We need to administer our shock at a very specific time during the cardiac conduction cycle. And so because of that, we need to use what we call synchronized cardioversion. So we need the machine that's going to administer the shock to also read the electrical activity coming from our patient and only administer that shock at a very specific time in the cardiac cycle. So that is the type of cardioversion, synchronized cardioversion, that we would use for a patient in atrial fibrillation that is unstable. So here's our atrial fibrillation. Here's our cardioversion. It is synchronized to come in at an exact point in the cardiac rhythm. The shock is administered, and then hopefully what we see in our patient is this restoration of normal sinus rhythm. We can also use a procedure called ablation. If we know where the abnormal electrical activity is coming from in the heart, we can administer a high rate of or high heat signal directly to that cardiac muscle. So we go in with catheters directly in the spot in the heart where this electrical activity is coming from, and we essentially use our catheters to burn away that heart tissue, causing scarring and damage that will hopefully stop that ectopic kind of pacemaker from producing this abnormal electrical activity. And there are also some surgical interventions that we can use. Sometimes for patients maybe who have permanent AFib with a really fast rate that we can't get under control, we may use surgery to just destroy the conduction system and we'll take over with a pacemaker. That's one type of surgical intervention that we can use to correct these defects.